Okay, well, welcome to week 2. This is Pharmacokinetics week 2, which is a nice continuation of Pharmacokinetics week 1. Let's see. Okay, so the primary focus of this discussion is about drug metabolism. Drug metabolism is, remember, one of those pharmacokinetic principles. It's what the body does to the drug. And like your slide says here, physiologic metabolism is the mechanism whereby an administered agent, referred to as a xenobiotic, and this, of course, has nothing to do with the antibiotic, anything that is introduced to the body that doesn't belong there, that's not a naturally occurring phenomenon, is referred to as a xenobiotic. So it might be a medication or it might be something else, but anything that doesn't belong is referred to as a xenobiotic. So drug metabolism is the mechanism by which a xenobiotic is converted to a form that prepares it for elimination. Because like the second bullet point here says, when the body perceives the presence of something exogenous, it immediately begins to prepare it for elimination. Your body doesn't like things in it that are not naturally occurring. It doesn't matter if it's a drug or anything else that gets in or on your body that doesn't belong there. And you know this, I mean, there are just numerous examples in day-to-day life. If something gets in your eye, it might be like smaller than a grain of sand, but if something gets in your eye that doesn't belong there, your eye is immediately going to try to get rid of it. You're going to start to water, it's going to be irritated, you're going to be rubbing it all the time. You become consumed with this thing in your eye that you have to get rid of. You can't think of anything else. Same thing if you get a little 1 millimeter splinter in your foot. I mean, in the scheme of things, it shouldn't mean anything. But if you get that little 1 millimeter splinter or sliver of glass or something in your foot, and your body wants it out so badly that it focuses all of your attention to it, and you can't do anything else. Suddenly you're sitting there, with your magnifying glass or your cheater glasses from the drugstore and a pair of tweezers, and you're trying desperately to get this tiny thing out of your foot because it is so annoying. The same thing happens when you put a drug in the body. The body doesn't like stuff in there that doesn't belong. That is principle number 1. The body likes steady state. It likes the status quo. We are physiologically designed to prefer homeostasis, right? Where everything is in a steady state. The seesaw is in the neutral position. That's the way the body likes it. So anytime you introduce something into it to upset that steady state or to change the status quo, your body will immediately begin to try to get rid of it. And when it is a drug, when it's a pharmacologic agent, the body tries to convert it to a water-soluble form that is what's the word I want? Agreeable, susceptible, amenable to elimination. If your body wants to get rid of a thing that's inside circulation, the thing to do is make it water soluble so that it can be excreted. And that's really what drug metabolism is. Drug metabolism is the process by which a drug that is introduced into the body is converted to a water soluble form so that it can be eliminated. Remember, in the body you exist as either having lipophilic properties or hydrophilic properties. And yes, there are definitely things that have features of both, but one will typically be dominant. A compound will either be more lipophilic or more hydrophilic. So hydrophilia is water-loving, lipophilia is fat-loving, and like this slide says, in order to be able to have some sort of action in the body, any drug that's administered must have some degree of lipophilia. It must have some element of being able to interact with fat, because fat or lipid is the barrier that separates the extracellular space from the intracellular space. Remember that the cell is the smallest independently functioning unit of the body. Cells are encased in a cell membrane that is a fatty or lipid membrane, and then inside the cell you have your nucleus, which is like the brain or command central, and then you have your organelles, and the organelles conduct the business of the cell and maintain it as an independently functioning unit. And then a bunch of cells come together to make up tissue, and a bunch of tissues come together to make up an organ, and a bunch of organs come together to make up a body system. But the cell is the smallest independently functioning unit. So when drugs are designed to be administered to humans, they are designed to act act somewhere either on the cell membrane or in the cell, because that is the smallest independently functioning unit. So in order to be able to interact with the cell membrane or to cross it, every drug has to have some degree of lipophilia. Being lipophilic allows you to bind or interact with a lipid, which is great for the drug to work. But then if something stays bound or I am having totally word-finding difficulties. If something stays lipophilic so that it has this affinity for fats, it cannot be excreted. It can't mix with water. Remember, the lipid-water interface, the fat-water interface, doesn't mix. If you put fats in water, the fats will stay very separate, right? So a drug that has a lipophilic property makes it able to interact with the lipid part of the body, but it makes it unable to interact with the water part of the body, so it can't be excreted. If you want to be able to excrete a drug, you have to take that lipophilic feature of it and make it hydrophilic. And that is what drug metabolism is. Drug metabolism is the process by which your body takes the lipophilic piece of a drug and makes it hydrophilic so that it can be eliminated. So here's the cell membrane. Let me see if I can get my little pin thing that I'm not very skilled with, I know, but I guess I can do what we have to do here. So this, again, the whole thing is the cell membrane, and remember that the cell membrane is comprised of these lipid molecules that have hydrophilic heads, the little blue thing, and there's a hydrophilic head on the extracellular face, right, the outside of the cell, and there's a little hydrophilic head on the intracellular face, or the inner surface of the cell. And that's what makes the membrane able to interact with the watery content on either side of the membrane. But in the middle, the thickness of the cell membrane is lipid. These lipophilic tails are very fatty. They're hydrophobic and lipophilic, and they come together and they make that barrier. This is the lipid barrier that separates the extracellular space from the intracellular space. So in order for a drug to be able to truly either diffuse through this membrane or interact with it, it has to have some degree of lipophilia, because water and fat do not mix. So this is the classic, example of the water lipid interface. What you've got here is water here, and you've got fat or oil here, and they just do not mix, right? Fat can definitely keep water compartments separate. So the takeaway message thus far is that in order for drugs to be able to interact with the cells, they have to have some degree of lipophilia. But if they have any degree of lipophilia, they can't dissolve in water and be excreted by the kidney. So when you introduce a drug into a patient, what the body will do, because the body doesn't like unknown things to be there, the body will immediately try to convert that lipophilic piece of the drug to a hydrophilic piece so that it can be excreted. And sometimes this happens really fast, and sometimes it doesn't. Sometimes the drug is metabolized so quickly, you have to take it 4 times a day in order to be able to achieve a steady state in plasma to do the job. Other drugs only have to be taken like once a day, and some drugs even once every couple days, because they are so lipophilic and it takes a long time to metabolize them. But the bottom line is, in order for a drug to be biologically active, to do something to a cell, it has to have some degree of lipophilia. And the more lipophilic it is, the longer it will stay in the body. This prolongs its half-life. Remember, the half-life is the concept by which we can predict drug elimination. A drug's half-life is the time frame that it takes for your body to decrease the serum levels by half. So if you have a drug on board, and let's say you take the drug, and when you first are administered the drug, there's 100 milligrams in your body. If 4 hours later it's down to 50 milligrams, the half-life is 4 hours. And then 4 hours after that there will be 25 milligrams. And 4 hours after that there will be 12.5 milligrams, because it decreases by 1/2 every 4 hours. So the more fat-loving or the more lipophilic a drug is, the longer the half-life is going to be, the harder it's going to be to excrete it. And conversely, the less fat-loving, if a drug only has a little piece of it that's lipophilic anyway, it's going to be easy to convert to hydrophilia. It's going to have a very fast half-life, and you're going to have to take it several times a day to make sure it stays in your body long enough to do something. So again, lipophilic compounds are not filtered at the nephron. You have to be water-loving or hydrophilic to be excreted by the kidney. So in order to excrete a drug, the pharmacokinetic mechanisms that convert it from lipophilic to hydrophilic, that is metabolism. It's the physical process of converting a drug from lipophilic to hydrophilic. There are 4 primary mechanisms by which your body can do this, and they're labeled here: oxidation, dehydrogenation, hydrolysis, and cytochrome P450 degradation. The first 3, the name tells you what they do. If you oxidize a drug, you introduce molecular oxygen and you change the shape of the drug. You change its physical characteristics and make it more water soluble. If you dehydrogenate a drug, you take hydrogen ions off of it and change its structure and make it more water soluble. And finally, if you hydrolyze a drug, you take a water molecule off, H2O, 2 hydrogens and 1 oxygen, and by changing its form, you make it more water soluble. Cytochrome P450 degradation is the 4th mechanism of metabolism. It's actually the most common mechanism of metabolism, and of course, it's the one where the name doesn't tell you what it does, but that's what I get the big bucks for. Half of this lecture is me telling you what cytochrome P450 degradation is. But keep in mind, the message from this slide is there are 4 ways to take a drug and convert it from lipophilic to hydrophilic, and these are what they are. And so what that means is all drugs, all compounds in the body, whether it's drugs or naturally occurring elements, like everything, every compound are composed of elements. They're built from elements. You might remember the periodic table of the elements from your basic chemistry class. You have these basic elements in science: hydrogen, helium, oxygen, carbon, copper, nitrogen, phosphorus, and there's like a ton of them, and of course I'm going to embarrass myself by not being able to remember them, but there's a whole mess of elements. Every compound in the body is comprised of elements. They are a series of elements bonded together. The majority of naturally occurring compounds are built on the compounds or on the elements carbon, nitrogen, oxygen, and hydrogen. Of course, there are other elements that are inherent to physiologic compounds, but those are the core 4. Like everything in the body is structurally based on carbon, nitrogen, oxygen, and hydrogen. So everything, whether it's a naturally occurring compound or a drug, is built from the elements. So for example, glucose, right? Glucose, by way of scientific notation, is C6H12O6. That's C6 is 6 carbons, H12 is 12 hydrogens, O6 is 6 oxygens, and here they are. This is diagrammed out. So 6 carbons. Here's 1, 2, 3, 4, 5, and 6. 6 carbons, 12 hydrogens. 1, I'm getting sloppy, sorry. 2, 3, oh goodness. 4, 5, 6, 7, 8, 9, 10, and 11, 12, because there's 2 of them here. Never said I was an artist. And then O6. So you've got 1 oxygen, 2, 3, 4, 5, and 6. C6H12O6. So the point being that everything, whether it's a naturally occurring compound or a drug, is composed of a series of elements that are held together by bonds. Here's an example in the form of atorvastatin. This is a very commonly used drug that I'm sure you know as Lipitor. And this is the chemical compound of Lipitor. Like everything here has a element. It's just not labeled. Usually the corners of these structures are carbon. So these are all carbons. And then this separate thing that you see here is usually bound by hydrogen. So I don't know what all of the specific elements are, but these are all elements. Everything here is an element, even if it's not labeled, and it comprises atorvastatin. So the point is that every drug is comprised of a series of elements that are bonded together. And some of these bonds are very strong, and some of them aren't so strong. Some of them are quite weak, and they're easily stolen or easily moved. So if you introduce another element exogenously and you like thrust another element into the mix, the new element might steal a bond away and completely change the chemical structure of this thing. Any of those four processes, oxygenation, dehydrogenation, hydrolysis, and cytochrome P450 metabolism, are all processes that can change the chemical structure of a drug and change it from lipophilic to hydrophilic. And keep in mind that just removing or changing one single element, just disrupting one bond, can completely change the properties of a compound. For instance, here's an example that you may be able to appreciate. Here on the left of the screen as you look at it is ethane. Ethane in scientific notation is C2H6, right? 2 carbons. Here's my poor drawing skills again. 2 carbons and 6 hydrogens. 1, 2, 3, 4, 5, and 6. Ethane is poison. Even in very small amounts, ethane will kill you. You don't ever want to accidentally ingest ethane. This is very lethal. Add 1 oxygen to it. Just add 1 oxygen. So now it's C2H6O. This converts ethane to ethanol. Totally different compound. Ethanol will not kill you if it's used responsibly. Ethanol is the compound in alcohol, the kind of alcohol that we drink. So if you take ethanol that is cultivated in the Carneros region of Northern California and produce from it a fine Chardonnay and drink responsibly and not to excess. This is the 21st century, so I have to be so careful of everything I say. I am totally not advocating in any way that anybody drink to excess or drink irresponsibly, or heaven help us, drink and then drive. Do not drink and drive, right? I'm definitely CY my own A here. All I'm saying is that in very minuscule amounts, this compound, as you look at the left of the screen, in very small amounts will kill you. This compound on the right side of the screen, if it is used in moderation, paired with a fine meal, not used to excess and not used before you drive, it won't kill you. And the only difference is that one little addition. This was oxidized. This is an oxidation reaction. This ethane has been oxidized to ethanol, and it completely changes the way that it presents. That's the point here. So we can totally change the properties of a thing by just changing like one bond or one piece of the chemical structure. So I said the first mechanism of metabolism is oxidation. So here you see even yellow arrows showing us what's going on. This is just a very generic representation. RH is a very generic drug compound. It's like drug X. In scientific literature, RH is used to mean like anything, not any one drug specifically, just all drugs in general. RH is the pharmacologic agent. So this drug compound, whatever it is, now in this case it is cyclophosphamide, but RH can stand for anything. In this case, cyclophosphamide is oxidized. One oxygen is introduced to it, and it completely changes its chemical properties. Now it becomes cyclophosphamide mustard. This is the oxidized form of cyclophosphamide, and it changes it completely. Again, my primary goal here is that you appreciate that introducing one molecule and changing one bond can change the properties of a compound hugely. In this case, it's a matter of dehydrogenation. You've got your compounds on the left of the screen, right here, dehydrogenated. The hydrogen ion is taken off. So over here, you've got the same compound minus one single hydrogen. You'll notice it's not here anymore. The hydrogen is split off. This is dehydrogenated. And again, it will completely change the properties of this drug. Hydrolysis is the property by which you take off water, H2O. So when you hydrolyze something, you take off two hydrogens. So you notice here you've got CH3, and here you've got an oxygen. And in this version of the compound, the oxygen is completely gone, and two of the hydrogens are gone. And this thing is hydrolyzed, and it changes it completely. So any mechanism of metabolism just changes the physical property of the drug. And when we're talking about drug metabolism, changing the property of the drug will take a lipophilic drug, make it hydrophilic and ready for excretion. Now, the one where the name doesn't tell you what's going on is the cytochrome P450 cascade. And the cytochrome P450 cascade, interestingly, is the primary mechanism by which most pharmacologic agents are metabolized. 2/3 of all prescription drugs are metabolized by the cytochrome P450 family of enzymes. So we do need to know what they are. Because most drugs are metabolized by cytochrome P450 interactions are responsible for more clinically significant adverse drug reactions than any other cause. So, of course, it's important to know about it. The cytochrome P450 cascade is a cascade. It's a series of reactions. These are a series of oxidation-reduction reactions that ultimately result in a drug becoming hydrophilic and subsequently ready for excretion. So this diagram that I have, the best diagram I've ever seen for purposes of teaching this is in French. So it's, I don't know, I'm from New Jersey, I can't pronounce this, but it's something very French looking. It is the cytochrome P450 reaction cycle. And it just shows you that you introduce that drug. Like I said, RH is like the generic, general representation of any drug you give to the body. So you give the patient a drug. Drug goes into the body. That's RH. The first step in metabolism in the cytochrome P450 cascade is that drug is introduced to a low-spin iron molecule. And they come together. And when they come together, it changes the characteristic, and now it's got a high spin. A high spin molecule is a highly volatile one. It wants to react to something. It's like a magnet with feelers out there to pull something to it. And what it pulls in the cytochrome P450 cascade is an electron. This is the process of reduction. When you introduce an electron to a compound, you reduce it. So this is reduced from Fe3 plus over here to Fe2 plus the drug. And again, just this one act of removing one of these ions changes it totally. And it makes it very susceptible or very attractive to oxygen. So when you introduce oxygen to this compound, you have oxidized it. So here you reduced it. Here you oxidize it, and when you oxidize it, you come out with this compound. Now this compound is also highly volatile. It's constantly changing shape. It goes back and forth, as you can see, between this and this. The negative charge goes from here to here, back and forth again. Anyway, this highly volatile form of this attracts to it another electron. And so what you ultimately wind up with is this compound. You've got the drug, which is RH, with this high spin iron and a free radical oxygen attached to it. Well, that then is reacted with hydrogen ions, and then you hydrolyze it and split off water. Those two hydrogens take one of the oxygens, and what you are left with is this compound here. This compound here will very quickly liberate the iron, and what you are left with is an oxidized form of the drug. In other words, the drug went in and an oxidized form of the drug went out. But that oxidized form is very different. Again, remember the difference between ethane and ethanol. If you just introduce an oxygen, you can change the properties of something hugely. So you might say to yourself, well, self, why did I have to go through all of that? Why didn't we just introduce oxygen at this step and save ourselves everything else? And the answer is because you need a stepwise approach. You need a cascade. Because if you just went from drug to oxidized drug and there were no steps in between, it would be all or nothing. You'd give the patient a drug, it would be immediately oxidized and not active, and then what would you do with that? It would just come out the other end. You want the drug to be able to be active in the body for a while, so we need it to have some time frame where it is slowly and steadily degraded. That's why cytochrome P450 is so important. It slowly over time metabolizes the drug so that while this process is going on, the drug does remain active to lesser and lesser extents until it's finally ready for excretion, but it remains active for some period of time. That's what's so important about the fact that cytochrome P450 is a cascade. It's a series of reactions. Almost every pathway in the body is a series of reactions because otherwise it would just be all or nothing. You'd either be drug toxic or subtherapeutic. It wouldn't even have a chance to work. You'd put it in, it would get metabolized and excreted, or you'd put it in and it would stay there forever. And neither one of those is any darn good, right? So cytochrome P450 is a series of oxidation reduction reactions which facilitates the conversion of a drug to a hydrophilic form so that it can be excreted. That's the takeaway message up till this point. And I think I mentioned to you excuse me, that 2/3 of all prescription medications are metabolized this way. So some other things we need to know about cytochrome P450. The 2/3 of drugs that are metabolized by this pathway are referred to as substrates. If a drug is a substrate of the cytochrome P450 cascade, it's metabolized by that cascade. It needs that cascade to prepare it for elimination. A substrate is subject to metabolism by the cascade. And that's what 2/3 of all drugs are. But on the other hand, we have some medications that actually inhibit the cytochrome P450 cascade. They actually slow it down. And then other drugs actually induce or accelerate the cytochrome P450 cascade and speed it up. So we always need to know when we're giving patients medications, if we're giving them medications that are substrates, and if at the same time we are giving them medications that inhibit the cascade and or drugs that induce or trigger the cascade. And the reason for this is fairly straightforward. If you give two substrates at the same time, no big deal. Like I said, 2/3 of all prescription medications are metabolized by cytochrome P450. If you have a patient on polypharmacy, there's a fair chance that they're going to be on two medications that require cytochrome P450 for metabolism. This is to be expected and no big deal. It's like you open the door and two people want to walk out at the same time. Or you open the pathway and two drugs want to be metabolized at the same time. No problem. The potential for problems happens when you give an inhibitor at the same time as a substrate, because the inhibitor can inhibit the cascade from acting, so then the substrate cannot be metabolized. And the concern then is that you wind up with toxic levels of the substrate. And to go back to my door analogy, if you give one drug that's a substrate of cytochrome P450, that's the drug that wants to walk out the door. If at the same time you give a drug that is an inhibitor of cytochrome P450, that's a drug that's going to hold the door shut. So if one is holding if one is holding the door shut and the other drug is trying to walk out through the door, what's going to happen? The drug that's trying to leave or the drug that's trying to be metabolized can't be. It's stuck in there. Start taking a couple more doses and the next thing you know, your patient's going to be toxic. On the other hand, some medications are inducers of cytochrome P450. So if you give one drug that is a substrate and it uses this pathway to be metabolized and another drug that is an inducer, then the inducer actually cranks up the cascade. The drug that is the substrate is going to be metabolized too fast. It doesn't get a chance to develop therapeutic levels, and you wind up with subtherapeutic levels of the substrate drug. The drug just can't do its job. So this is why cytochrome P450 matters. Because 2/3 of all prescription medications are metabolized by it, it's really important to know, mostly if we are giving inducers and substrates, or inhibitors and substrates at the same time, because that will tell us if we have a risk for a drug either becoming toxic or a drug being subtherapeutic. Of course, numerous therapeutic agents are substrates of cytochrome P450. I've already said that. Several others are either inducers or inhibitors, and again, it's when you complex the inhibitors and the substrates, or the inducers and the substrates, that you're going to wind up with a problem. And there's no way to know, you can't memorize this. I don't know all of these off the top of my head. All you can do is when you're giving drugs, you look them up and you learn about them. And then after a while, you develop, you just remember, you have a knowledge database in your head of certain drugs. If a new drug comes into your world, well, you have to look that one up too. But it's just a matter of developing a knowledge base. In the beginning, it can be very intimidating. One last thing about cytochrome P450, just in case it wasn't complicated enough. There are many individual cytochrome P450 enzymes, many individual subtypes that are referred to as isoenzymes of this cascade. I remember it I think of it as cytochrome P450 as the generic name for the whole thing. I think of P450 as the last name, as the family, right, as the surname. In that family of cytochrome P450 enzymes, there are numerous first names or isoenzymes. There's a bunch of them. And each isoenzyme has its own little pathway. And so obviously the thing that matters the most is if you give a drug that is a substrate of one individual isoenzyme, you don't want to give the patient an inducer or an inhibitor of the same isoenzyme. That's where you can run into trouble. So these are some of the more common isoenzymes. There is cytochrome P450, 3A4, 3A5, or 3A7. These are the ones that are most prevalent clinically. In fact, I think I've already said to you that 2/3 of all prescription medications are metabolized by cytochrome P450. 50% of all medications are metabolized by the 3A4, 3A5, and 3A7 isoenzymes. So that's half the drugs right there. Some other important enzymes are 2D6, 2C9, 2C19, and 1A2, and there's others, and they're identifying new ones all the time. But again, the reason this matters is if you give the patient a medication that is a substrate of 3A4, meaning it needs 3A4 to be metabolized, you don't want to simultaneously give an inhibitor of 3A4. Now, if you're giving a patient a drug that is a substrate of 3A4, you can give an inhibitor of 1A2. That's not as big a deal. These are two separate isoenzymes. They really don't have that much in the way of crossover. However, there are several drugs that are substrates, inhibitors, or inducers of more than one isoenzyme. So, in other words, as confusing as this can be, there are some drugs that are substrates of, say, 3A4 and 2C19. So you don't want to give inhibitors of 3A4 or 2C19 while you're at it. And then, excuse me, if you really want to make your life miserable, keep in mind that some drugs might be substrates of 3A4 and inhibitors of 2D6. So they're not mutually exclusive. Just because a drug has some relationship to one isoenzyme doesn't mean it can't have a relationship to another one. And like I said, you just got to look them up. When you're first learning, you just look them up. And then you develop a knowledge base, and then you know. But developing that knowledge base can be painful. So let's see. So I said 3A4, 5, and 7 are the most clinically common. This is just a representative list. There's a ton of drugs that are substrates of these things. And again, I will never ask you, on a quiz or anything to like memorize all of these. It just can't be done. It's the concept I want you to understand. The specifics, you just have to look them up when you go to work, because a lot of this stuff is used every day. Macrolide antibiotics, I mean, half the world has been on azithromycin, right? Benzodiazepines, heaven help us, half the world has been on alprazolam or lorazepam or diazepam or temazepam or some other apam. The HIV antivirals, of course, they're very focused to one population, but of that population, everybody's on them. Prokinetics are drugs like Reglon. Antihistamines, I mean, good heavens, who hasn't taken those every now and again? Calcium channel blockers, the statins to lower LDL cholesterol. Excuse me. Going over to the next page here, we've got morphine, propranolol, sildenafil is one of the erectile dysfunction drugs. Zolpidem is, Ambien. I mean, a lot of these drugs are very commonly used. So you need to look them up, and then you'll know. These are examples of substrates. These drugs are metabolized by cytochrome P450. Now, these are some examples of inhibitors. So if you take a drug from the last screen and combine it with a drug from this screen, this drug can inhibit the metabolism of the drugs from the other screen. So suppose you have some little old lady, and she's been on 0.25 milligrams of Xanax BID for like the last 30 years. It just helps her with her anxiety. Of course, we never want anybody to be on benzos long term, but sometimes people are, especially our older population. So you might have somebody admitted to the hospital who's 75, who's been on this for 10 or 15 years. Okay, no problem. But then, while she's in the hospital or while he's in the hospital, gets put on ciprofloxacin for, say, urinary tract infection. Well, ciprofloxacin inhibits cytochrome P450 3A4, which is the enzyme that metabolizes the alprazolam. So now that alprazolam can't metabolize as efficiently, and levels become higher and higher and higher in the body, and the next thing you know, the patient's becoming loopy, or maybe starting to fall down, or feeling tired all the time. It's because the alprazolam has accumulated in toxic doses because the cipro interfered with its metabolism. That's how this cytochrome P450 stuff goes together. So these are some examples of inhibitors of 3A4, 5, and 7. Like I said, we do have some other clinically relevant isoenzymes like 2D6. So these are some substrates of that. These are inhibitors of 2D6, so you don't want to give one of these to somebody who is taking a drug on the last screen, and that's why, we always review our orders and know your drugs and know what you're administering. And these are just a few examples. There's a ton more out there. Like I said, I'm not asking you to memorize drugs. I'm asking you to understand the concept. So I won't ask you list 5 drugs that are inhibitors of the cytochrome P450 2D6 isoenzyme, but what I may ask you is to tell me what happens if you give an inhibitor of 2D6 to a patient who is on who is on a substrate of 2D6. Let's see, the greatest risk in giving combinations of substrates and inhibitors or substrates and inducers that are affected by the same isoenzyme. So we've established that clearly, right? So now that you understand the process, I'm going to give you some clinical examples. All right, clinical examples. All right, so and these are a couple of real world examples. These aren't things I made up. These are things that actually happen. The first one was a patient who she was admitted to the hospital as a direct admission for management of what was diagnosed as outpatient treatment failure for community-acquired pneumonia. So this lady shows up, like her primary care physician admits her as a direct admit. Now, I don't know if you that are listening to this are familiar with the concept of direct admissions. I know some places it happens fairly often, some places never. So in some areas, everybody goes through the emergency room, but in some areas, people are directly admitted to a hospital floor bed under the orders of an attending physician. So anyway, this lady did not go to the emergency room. She was admitted as a direct admit. Her admitting complaints were shortness of breath, pleuritic chest pain, worsening muscle weakness over the last week. What had happened was she had been seen as an outpatient and diagnosed with community-acquired pneumonia. She was put on an appropriate antibiotic regimen, but she continued to deteriorate. A week later, she was no better. So her primary care doc admitted her with a diagnosis of outpatient treatment failure and admitted her for IV antibiotics. This was a 61-year-old female. She had some chronic conditions that were all well controlled. I mean, her primary care doc, did a good job. This was not a shoddy clinician. And her chronic conditions were not like all that earth-shattering. The usual suspects, like osteoarthritis. She had hypothyroidism, dyslipidemia, hypertension, just nothing any big deal, and they were all well controlled. So anyway, as an outpatient, she had been diagnosed with community-acquired pneumonia, and she had been put on Biaxin, clarithromycin, 500 milligrams BID times 14 days. Now, this was a few years ago when Biaxin was very commonly used for outpatient management of pneumonia. So she went on this drug therapy, and initially she got better, but then her symptoms appeared to return, and that's when she developed this shortness of breath, pleuritic chest pain, and worsening muscle weakness. So her physical examination, like it's shown here, she was in mild respiratory distress. Look at her vital signs. The only one that is really remarkable is that respiratory rate of 32. That really is very consistent with pneumonia. And she also had like a very low-grade temperature. These are the medications she was on coming into the hospital. Or actually, these are the medications she was on when she was started on her clarithromycin. Lisinopril for blood pressure, atorvastatin for dyslipidemia, levothyroxine for her thyroid problem, beclomethasone is a steroid nasal inhaler. She probably had allergies. Doxycycline, a really old-time blood pressure medication. Ibuprofen, she probably got headaches once in a while or arthritic pain. And then she was put on the clarithromycin for her pneumonia. Now her labs, and I don't expect all of these to make perfect sense to you, but her labs revealed a basically well-controlled and healthy lady. If you look at them, her metabolic panel is all within normal limits. Her liver function test is normal. Her BUN and creatinine are just a little on the higher end of normal for a 61-year-old lady, but this could easily be explained by a little bit of volume contraction from her pneumonia and her low-grade temps. Her TSH is a little bit elevated. Remember, she's on thyroid hormone, so we know she's got a thyroid condition. Her cholesterol is not horrible. She's on the highest dose of atorvastatin that she could be on. And the numbers here from her blood count are all pretty normal too. So this is a lady who was pretty well taken care of on an outpatient basis. And then her primary care doc diagnosed her with pneumonia and put her on Biaxin, clarithromycin. So the problem is that clarithromycin is a very powerful inhibitor of the cytochrome P450 3A4 isoenzyme. And the atorvastatin that she was already on is a substrate of the cytochrome P450 3A4 isoenzyme. And if you think about it, the thing we always worry about with the statins, with those cholesterol-lowering drugs, is muscle breakdown, is myositis and rhabdomyolysis. Now, this lady was on 80 milligrams of atorvastatin, which is the highest possible dose of atorvastatin, and then she started taking a drug that blocked the metabolism of that atorvastatin. So the atorvastatin then was allowed to accumulate in toxic doses. It accelerated muscle breakdown, clogged up her kidneys, and put her in acute renal failure. And by the time anybody realized what was happening, she was in advanced rhabdomyolysis, advanced renal failure. and she died. I mean, they tried to dialyze her, but she just died. This was a totally preventable drug reaction. I mean, it was sad for everybody involved. Obviously sad for the patient and the patient's family, but it was sad for the primary care clinician too, because, you know, I mean, it's easy to say, oh, he should have known, but we all make mistakes in the course of our day-to-day jobs, and it's one of the reasons that multiple checks and balances are so important for us in healthcare. If the physician or the nurse practitioner or the PA misses it, maybe the RN will get it. And if the PA or MP or physician and the RN miss it, maybe the pharmacist will get it. Hopefully somebody will realize that there was an error here. That kind of stuff happens all the time. In this case, it got by everybody, and this lady developed rhabdomyolysis, and she just died a totally preventable death at the age of 61. I mean, it's really scary, and it really reinforces why it's so important that we do our job. You may not be the ones prescribing these drugs, but you're the ones administering them. And so when you see a new drug introduced into the mix, it's a good idea to take just 2 minutes, look it up, and make sure there are not any clinically significant interactions, because you might be the check and balance that saves this patient from, in this case, what was a very tragic, catastrophic, and totally preventable death. So that's just, one very sad example of what happens here. Another example of cytochrome P450 metabolism is in this 46-year-old male. So this is a little bit of a different story. This man was admitted to a step-down unit for management of altered mental status and depressed respirations. And his medical history was significant only for long-term chronic back pain managed with methadone. This gentleman was a patient of the VA. He was a very long-term patient of the VA. He had been on methadone for years. And everybody involved in his care was sure that he wasn't abusing, he wasn't taking more than he was supposed to, like he wasn't doing anything wrong. He was using the same dose that he had used for a number of years, and suddenly he became what appeared to be methadone toxic. I apologize if you're hearing what seems to be some weird delays in this audio. It's because I pause it every time I have to cough rather than make you listen to it every time. Anyway, this gentleman was diagnosed with methadone toxicity. The methadone dose was stable. It had not been recently changed. It was determined that he did not purposefully or accidentally overdose. He wasn't taking any other opiates. He wasn't using heroin or any, morphine or Dilaudid or anything like that. Like I said, everybody involved in his care was very confident that he wasn't doing anything wrong. He was just taking the same dose of methadone that he had taken for a long time, but suddenly it was making him have an altered mental status and depressed respirations. A review of his medication list, there was nothing new. There were no drugs to cause an interaction. So nobody knew what was going on. His methadone was held for 3 days and he improved significantly, and that was it. Life saved. But a post-morbid analysis, in other words, reviewing the case after it was all over, revealed that the only change in his circumstances was that recently he had made an attempt to quit smoking. And what somebody who was very smart or very well informed figured out is that methadone is metabolized by 2 cytochrome P450 enzymes, 3A4 and 1A2. And while he wasn't taking anything that affected 3A4, cigarette smoke has certain hydrocarbons that are inducers of cytochrome P450 1A2 isoenzyme. So for the last several years, and for the whole time that he had been put on methadone and had a dose titrated up and then been maintained, he was a smoker. And so by smoking, he was introducing inducers of the 1A2 isoenzyme. So it was accelerating his metabolism of methadone, so he was on a higher dose to keep up with that. Now, nobody knew what was going on. It wasn't like anybody figured this out at the time. It was just, you know how it is when you start a drug. You start drugs on somebody, you titrate them up to the dose that works, and then you leave them there. And because he was a smoker, he was metabolizing them really fast, so he got titrated up to a certain dose, and everything was fine. But then when he stopped smoking, he stopped introducing an inducer. so the methadone wasn't metabolized as fast as it had been, and he developed basically methadone toxicity or methadone overload. So he had to have his dose of methadone reduced. And that was it, and that's the way it'll be unless he starts smoking again. And if he starts smoking again, he's going to accelerate metabolism of the 1A2. He's going to accelerate 1A2 isoenzyme. He's going to accelerate metabolism of his methadone, and the dose will have to be increased again. So that's the way it all shakes out. As the patient decreased his cigarette use, he decreased induction of an isoenzyme that metabolized his methadone. Pretty cool, huh? Unless you're the patient who wound up methadone toxic. But at least now everybody understands what's going on. So that's cytochrome P450, and it really is an important concept in terms of drug metabolism. So I hope you understand the process. If you have to listen to this slide set a few times over, that's why it's recorded. You can listen to it as many times as you need to. All right, let's look at a few last concepts before we close the door on this topic of pharmacokinetics. The first pass effect, another thing to complicate your world here. The first pass effect refers to the fact that when a drug is administered orally, a large portion of that drug passes through the liver before it even makes it into circulation. This is referred to as the first pass effect, like all with capital letters. It's like a phenomenon. The first pass effect. So you take a drug orally, it's subject to all those other things we talked about: salivary enzymes, gastric acid. It has to get absorbed by the gut. It relies on good vasculature in the gut. Then it gets distributed into circulation. But the first place it goes is through the liver, which is basically the organ of metabolism. So it goes through the liver. Drugs that are taken orally are going to go through the first pass of metabolism before they even get into arterial circulation. This is the first pass effect. So what that means is if a drug is administered in an active form, which most drugs are, it's going to be metabolized and broken down and have its effectiveness decreased before it even reaches circulation. Now again, this isn't a bad thing. We know this. I mean, this is all the drug manufacturers know this going in. So drugs that are formulated for oral administration are formulated in doses that are high enough to expect that it's going to be metabolized before it even gets into circulation. That's fine. But one thing you want to keep in mind is that some drugs are administered as inactive drugs. This is referred to as a prodrug, and they need to pass through the liver to activate them. Because remember, metabolism, in the strictest definition, metabolism means that the chemical structure of the drug is changed. Remember, it's either oxygenated, dehydrogenated, hydrolyzed, or subject to cytochrome P450 oxidation reduction reaction. All four of those, all they do is change the structure of the drug. Now, if the drug was already active to start, changing the structure of it is probably going to make it less active. But some drugs are administered in an inactive or prodrug form with the expectation that they will undergo a metabolic change into their structure when they pass through the liver, and that metabolic change will activate them. So again, if you don't know, you have to look them up. Most drugs are administered in an active form, but some drugs are administered in an inactive form. And if you don't know, you just, have to look them up going in. So obviously, if hepatic function is impaired, this will impact drug bioavailability in some way. If the liver is not functioning optimally and a drug is administered in an active form, then it won't be metabolized the way it should be. Metabolism will be inefficient, and there is a risk of toxicity. I mean, it makes perfect sense. You give a drug in an active form, the liver doesn't work right, the liver can't metabolize it, the drug stays active. And then as you keep taking subsequent doses, there is a risk of toxicity. But on the other hand, if you give a drug in a prodrug or inactive form and it needs the liver to activate it, if the liver isn't functioning properly, then you can't activate the drug and you may wind up with subtherapeutic levels. So let me give you an example of this. And those of you that have been in nursing for a while may even remember what I'm talking about here. But, maybe, I don't know, 7, 8 years ago, the years just all blend together after a while. Most of you are probably familiar with Plavix, right? Plavix is the brand name for a generic drug called clopidogrel. This is a platelet aggregate inhibitor. It's very commonly used in patients that have coronary artery disease and had stents put in to reduce their risk of clotting, right? So Plavix, real common drug. We use it to manage coronary artery disease, especially in patients who have stents. Well, clopidogrel is a prodrug. When you take this orally, it's inactive, it has to pass through the liver, and it is a substrate of the cytochrome P450 2C19 isoenzyme. So when you take clopidogrel, you need cytochrome P450 2C19 to activate it. And that's fine because most of us, we have plenty of 2C19, and if we take clopidogrel, it'll be activated and everything will be good. But if there's some circumstance where 2C19 can't work, like maybe some patients just have a genetic deficiency in the 2C19 isoenzyme, and other patients take medications that inhibit the 2C19 isoenzyme. Either way, if 2C19 can't work, it can't activate the clopidogrel, and clopidogrel can't do its job, which is to help prevent coronary artery events. 7 or 8 years ago, it's all of a sudden it got really famous. Everybody was talking about the fact that one of the proton pump inhibitors, Prevacid, was an inhibitor of cytochrome P450 2C19 isoenzyme. And then it was like, oh no, if a patient's on Plavix and they take Prevacid, the Prevacid inhibits the enzyme that activates the Plavix, then the Plavix won't work and the patients will have cardiac events and life will be horrible. So like all the cardiologists were de-seeing the Prevacid on their patients who took it. Then of course all the GI docs were upset because they're like, this is overkill, this isn't, we don't need to go this far, and we don't do it. And it was a big thing for a little while. It's kind of faded away now. But the principle illustrates this concept I'm talking about very nicely. Prevacid inhibits 2C19. Clopidogrel requires 2C19 for activation. So if you take them together, the Prevacid is going to inhibit the isoenzyme that activates clopidogrel, and clopidogrel will not get the opportunity to be activated, and it won't become active. So you'll have subtherapeutic levels, and it can't do its job. So I guess that's all I have to say about that. I know this has become a little torturous here. It will, you'll take some time and probably just need to go over it again. But before we leave the topics of pharmacokinetics, we have just one more concept to discuss, and that's drug elimination. After the drug has been converted to a hydrophilic form, it has to be eliminated. And you know that the kidney is the primary route of elimination, although there are others. Some drugs are excreted by exhalation. We dissolve them into respiratory gases and excrete them that way. Some drugs just pass through the GI tract, do their job in the gut, and they are eliminated via the other end. And some drugs are eliminated by way of breast milk, which is especially important to know for when you have obviously a breastfeeding mom. So we always want to consider the route of elimination when evaluating whether or not a drug is appropriate for a patient. But keeping in mind, generally speaking, the kidney is the major route of excretion. So because the kidney is the major route of excretion, we have to consider renal function, keeping in mind that there are 3 primary mechanisms that contribute to renal excretion. There's glomerular filtration, tubular secretion, and tubular reabsorption. And abnormalities in any one or ones or all of these things can impact how a drug is excreted. So here's the renal tubule, and okay, yeah, my little pen is working here. So this is the way blood is filtered, and everything that you don't need is filtered out, including drugs, right? So first you have the glomerulus, because I said glomerular filtration was one important thing. So here is the glomerulus. The glomerulus is where the renal arteriole sort of bunches up here inside of this yellow thing known as Bowman's capsule, and this is where renal filtration begins. In the glomerulus, there's arterial pressure here, like arterial blood pressure is pumping the blood into the glomerulus, and that pressure will help diffuse all kinds of things in the blood vessel out into Bowman's capsule, which is the very beginning of urine formation. So a lot of stuff gets pushed out of the glomerulus. Excess fluid, excess drugs, sugar, electrolytes, red blood cells, proteins, all kind of stuff get thrust into Bowman's capsule here. And then the process of tubular secretion and tubular reabsorption begin. So you've got Bowman's capsule, which becomes the tubules of the nephron, right? This is the nephron, this yellow stuff. This is where the urine is forming. This is where the waste products are accumulating. Wrapping around the nephron is the renal arteriole, these blood vessels. So what's happening here is both tubular secretion and tubular reabsorption. Secretion is when stuff is secreted from the blood vessel into the nephron. And reabsorption then is when the stuff that your body wants back comes out of the filtrate, out of the nephron, and back into the blood vessel. And this is just a constant process around the nephron all the way up until the formation of the renal veins, or the renal venules. And at this stage of the game, by the time you get here, what happens, supposed to be, that everything that you want to keep in the blood is in the venule, and everything that you want to waste and excrete has been deposited in the collecting duct. And in a healthy patient, that's the way it is. Clean, filtered blood by way of the renal vein is taken back to circulation, and all of the waste products are dumped in the collecting duct, and they get drained into the renal calyces and become urine. So what's happening here, this process of filtering out blood and excreting drugs, is glomerular filtration up here, tubular secretion, and tubular reabsorption. And all of that has to be working right to have good renal excretion. Things can go wrong with any one of these pieces. Glomerular filtration can go down if the patient is hypovolemic, if the patient is in congestive heart failure, the patient has very low blood pressure, anything that decreases the pressure with which blood hits the glomerulus. By the same token, secretion and absorption can be impaired from a lot of different consequences. There can be poor pressure in the filtrate, there can be poor pressure in the renal arteries, there can be autoimmune disorders that change the membranes of these things and make them less amenable to the process of moving waste back and forth. So the bottom line is, in order to have good renal excretion, you have to have good glomerular filtration, good tubular secretion, and good tubular reabsorption. Abnormalities in any of those can impact excretion. So that's why we want to know if the patient's got impaired renal function. Finally, dosing. I guess this is the very last thing we want to talk about before we call this a day. Dosing. The goal of dosing anything is to maintain a steady state within what we refer to as a therapeutic window. The therapeutic window is that place, that level that is above minimally effective but below minimally toxic. So our goal is to achieve a steady state in the patient's bloodstream where at its very lowest level, the drug concentration is still above minimally effective, and at its very highest level, it is below minimally toxic, because always we want drugs to remain effective but not toxic, right? Generally speaking, 5 half-lives have to pass before a steady state is maintained. And like I said, steady state is that place where the lows and the highs are the same. They're equal. They're equal to each other. And I'll show you a diagram in a minute. Usually 5 half-lives have to occur, or 5 doses. So for instance, here you go. So you give Where's my little pen? The patient starts a new drug therapy. You give dose number 1. Well, of course, when you first give the dose, there is no serum level. There's nothing in their drug. They're at level 0 because they don't have any on board yet. You give them their first dose, and their serum level rises. It rises to about here. And then their body starts to metabolize it, and the levels go down. But before it's totally gone, you give the second dose. And after the second dose, since they already had some left over from the first dose, the second dose will reach a higher peak, which is now, somewhere around here. And then they will begin to metabolize it for excretion. But then, before they get rid of it, you give the third dose. And the third dose starts out at a higher level because they already have the products of doses 1 and 2. So now you take dose 3, and now it shoots them up above this level that we call minimally effective. So for the first time, the level has reached an effective concentration. But the patient will begin to metabolize it and excrete it, so it'll drop. But then you'll give the fourth dose. And now the fourth dose will shoot them up to a peak that is solidly above minimally effective, but hopefully below minimally toxic. We want drug levels in the body to live here, between minimally effective and minimally toxic. Once you take that fifth dose, you usually have gotten to this place where the lows, like you see here, all the lows are constant and they are above the minimally effective concentration. That means in a 24-hour cycle, the serum level is always above the minimally effective. At the same time, the peaks are all constant and they're below the minimally toxic concentration. That means that in a 24-hour period, this patient maintains a level that is above effective but below toxic. So it's going to work without making them sick. That's our goal, and it usually takes about 5 doses to get there. So if the patient is on a drug that is a TID drug, the 5th dose is going to be on day 2. By day 2, they're at a steady state. If they're taking a drug that is a once-a-day drug, then it's going to be 5 days before they're at a steady state. Now, there is the occasional exception to that, and that's what you see on the next slide. Some drugs have such a wide range between the level that is minimally effective and the level that is minimally toxic, is that early on we can give them a lot and shoot them up into this stratosphere really fast. And a good example of this is azithromycin or a Z-Pak. I'm sure that most of you are familiar with the Z-Pak. They're very popularly used. And what you do with a Z-Pak, remember, is you get the little foil pack that has 6 pills in it. And they're each 250 milligrams. On the first day, you take 2. The first dose, you take 2. So those 2 pills is 500 milligrams. That shoots you way up, well above minimally effective. You're still a far cry from minimally toxic, but you're well into the effective concentration. So even as the body begins to metabolize and excrete it, you still stay above the effective dose. And then you take, the next day you take 250. And that shoots you up even further into this range. You're still nowhere near toxic because the range is wide, but you're well into that therapeutic range. And then the patient begins to metabolize it, and then the patient takes the 3rd dose and it shoots them up even more. And you get the idea now. Then they take their 4th dose and that shoots them up even more, but they're still not toxic yet. And then they take their 5th dose, and that's the last one in the pack. This is a 5-day treatment. So that 5th dose, because they're not at a steady state, every time they take a dose, they're going even higher. This dose gets them up to the upper limits of safety. Now, they're not going to take any more, but it's going to take them such a long time to metabolize this that even on day 6 and even on day 7 and even on day 8, the serum level is still above minimally effective. So even though they're not taking the pills anymore, they still have a therapeutic amount on board. So in this case, a 5-day regimen actually remains above minimally effective for 8 days, and that's enough to do the job. That's why they only need to take it for 5 days. So that's the point about dosing and minimally effective and minimally toxic. I know I've used those terms intermittently throughout this discussion. Hopefully that clears up what they mean a little bit. All right, now to wrap this up, just a few little reminders here. This is the AVOID acronym to minimize drug interactions. AVOID: A, V, O, I, D, and then M. AVOID, and the M is for family history, because family history does confer some tendency to drug metabolism and pharmacokinetic properties. So AVOID M can help you keep in mind how to avoid or minimize drug interactions. Then, just by way of reminder, we do have some special populations to consider. In pregnancy, the primary issue with a drug is, does it cross the placenta or not? In pregnancy, it's not fetal circulation that has to eliminate a drug, it's maternal circulation. So we're not so much worried about like the fetal renal function, because there really isn't any. We really care primarily if the drug will cross the placenta. A drug may be safe to give a pregnant woman that is not safe to give an infant or a small child, because like I said, if the drug doesn't cross the placenta, then the fetus's body doesn't have to deal with it. Now, if you give that same drug to an infant, the infant circulation does have to deal with it, and it may be a whole different story. So bottom line, in pregnancy, we worry about, does a drug cross the placental barrier? Conversely, in a breastfeeding woman, now the issue is, does the drug cross into breast milk? And some drugs cross the placenta that don't distribute in breast milk, and vice versa. So you can't assume that a drug that is safe in pregnancy is safe in breastfeeding. That is not always the case. Because now if the drug crosses into breast milk, now the infant's going to ingest it, and it's the infant's mechanisms of metabolism and excretion that we have to be concerned about. So if a drug is safe to give to an infant, it is typically safe to give to a breastfeeding mother. If a drug isn't safe to give directly to an infant, it should not be given to a breastfeeding mom if it crosses over into breast milk. And how do you know? You just have to look it up. There's no other way to know. In pediatrics, there are several issues in pediatrics, and we have some readings linked in your course here, so I won't go into great detail about it. But remember that, like infants, infants and neonates really have a large percentage of body water, so that changes the way a drug can be distributed. And also, protein binding is of particular interest, like your slide says, because infants have less protein, number one, and neonates especially make bilirubin, which competes for protein binding, number two. So if you give a neonate a drug, which you probably won't unless you work in a NICU, if you give a neonate a drug that binds to protein, it can displace bilirubin, and then the bilirubin can cross the blood-brain barrier and can cause serious brain damage. So this is a concern. And then routes of administration in neonates and infants, like they have some totally different considerations too. But like I said, there are links in your learning module that you can read about that. And then finally, the elderly population. I think I've alluded to this sort of off and on in these discussions for last week and this week, but the elderly also have some different pharmacokinetic properties. The elderly have less water. Infants have a lot, and the elderly don't have very much. Proportionally, the elderly have more fat. Now, overall, the elderly lose fat too, but they lose water more. So proportionally, the elderly population have more fat. So drugs are more likely to dissolve in fat if they have any degree of lipophilia at all. So drugs with long half-lives, it's even longer half-lives in the elderly patient. Also, elderly patients do have age-related decline in renal perfusion. So and it's not illness, it's just normal age-related decline in renal function. So we have to consider that in terms of excretion too. So definitely several different populations have some significant considerations in terms of pharmacokinetics. But I think that's all I've got for you. So I hope that this was helpful. As always, you know where to find me if you need to. And I will see you next week.